what exactly is a heart attack? So heart is a muscle. So heart requires a blood supply of its own.
A discussion about youngsters getting heart attacks. There are videos also floating around on YouTube. Does this happen a lot more in South Asian population as compared to the Western population comparatively?
I would say there is no regional predilection like that, but yes, we Asians are slightly more prone for having a heart attack at a younger age than the Western population.
One should see and say that, okay, like I really need to go and see a cardiologist, or who should I go to?
When you have a burn in the chest, it could be a symptom of heart attack, period. Till the age of 70 or so, the men have a higher chance of having a heart attack. But women are more likely to die from heart attack, is what the data says.
Hey guys, I'm Tarun. I'm co-founder of Orange Health Labs, and welcome to the Orange Club podcast. Here on this podcast, we're going to get health experts and incredible doctors from across the country to talk about their expertise on matters of health and well-being. Today, we have Dr. Dimpu Edwin, who is a consultant cardiologist in Aster RV Hospital in Bangalore. He is very well known in the academic circles and in the circles of interventional cardiology. His special interests are on topics of cardiology imaging, and he works a lot in the field of interventions in complex coronary diseases and also structural heart problems. With no further ado, I would like to introduce Dr. Dimpu Edwin. Thank you so much, doctor, for joining us today for this podcast.
Thank you. Good evening, viewers, and thank you so much for giving me the opportunity to be here. And it's a pleasure that you guys are doing this, and I want to congratulate each and everyone from Orange team for taking this initiative to bring out awareness among the people and also the viewers regarding the important myths that there are surrounding heart attack, and also what is it that someone should know about their heart health. Thank you, Tarun.
Thanks so much, Dr. Edwin. So this is like a topic close to my heart, literally, so to speak, right? I've seen this condition many times over in my family, right? And it's very personal. But let's start with just the basics, right? What is a heart attack, right? And oftentimes you hear this term called cardiac arrest. So how is these two terms related? Are they same? How do you define it?
That's right. So as we all know, we have heard this term which is used time and again. Most often, actually, it is used instead of each other, but they are not one and the same. So, a heart attack, what exactly is a heart attack? So, heart is a muscle, as we all know. So, heart requires a blood supply of its own. And a heart attack essentially refers to a process where the blood supply to a portion of the heart is cut off. So, depending on how big the portion is, it can cause that much bigger a damage when the portion of the blood supply is cut off. And also, depending on how long the blood supply remains cut off to the heart, it can cause so much of a long lasting damage. So, a heart attack essentially is the cut off of blood supply, and general terms of major and minor heart attack are used when it is a smaller portion of the heart which is at risk, at jeopardy. It is called as a minor, and major would be somewhere a major blood vessel is cut off and it needs the time is muscle there. Whereas cardiac arrest is something which generally refers to a condition where the heart has gone into an electrical storm. So arrest refers to not just a cut off of blood supply, it is a electrical phenomenon where the heart is ceased to function because of either too rapid a rate or it has just come to an electrical standstill. So, a cardiac arrest can be caused by a major heart attack, as I've mentioned earlier. That the heart attack is a cutoff of blood supply, and if it is a big blood supply which is cut off, then it can cause an electrical standstill. So, cardiac arrest is simply an electrical phenomenon, and cardiac attack, heart attack, is mainly a blood cutoff of blood supply, and it doesn't essentially need to be a electrical standstill or a too rapid a heart rate as we speak.
So this is the same term as what we use AF and VF, right?
Yes.
Atrial fibrillation and
Yeah. So
ventricular
fibrillation
fibrillation.
essentially means that heart is literally fibrillating. The term itself says that it is a flutter. So it's contracting without any particular order, and it is going too fast, too rapid a rate. So when it is an atrial fibrillation, we generally talk about the upper chambers of the heart, which are otherwise called as atria. And when it is ventricular fibrillation, it's the lower chambers of the heart, which is so typically people can tolerate atrial fibrillation without having too much of a symptoms and just some minor symptoms. But a ventricular fibrillation is a lethal entity, which is usually most often than not caused by a heart attack, major heart attack.
So, I mean, there is a lot of discussion about youngsters having getting heart attacks these days online. There have been cases that have been reported. There are videos also floating around on YouTube. Does this happen a lot more in South Asian population as compared to the Western population comparatively?
So I would say that there is no regional predilection like that, but yes, we Asians are slightly more prone for having a heart attack at a younger age than the Western population. And also, the main difference between the media hype which is going on and also what one needs to know is that, most importantly, we do not know, there are no existing tests, or like, there is no accurate 100% accurate test which will tell us whether you are predilected to a heart attack. So we would not know whether or not you have a heart attack tendency by just doing some tests. It's always a polygenic thing. It's a multiple factors which come into play. So yes, there are of late a lot of young people who are having a heart attack, which is all of a sudden, and that also goes to say that we are also having a lot of works which are um, more stressful. We have become more sedentary. The food what is going into the mouth is like hardly being watched. And of course, fitness is only something which people are considering as a extra or a bonus. If they have time, they do it, rather than something which is imperative thing for someone to follow.
True. You talked about the difference between the races, right? Like between Western and the South Asian population, and also you're saying that increasingly younger people are getting this thing. But is there also difference by demographics, for example, between men and women in terms of having heart attacks?
Yes. So there is slight difference in the heart attack when you compare it with and ethnicity. So generally, it is said that till the age of 70 or so, the men have a higher chance of having a heart attack. But women are more likely to die from heart attack, is what the data says. But the general fact remains this, that it's a very important thing to note that women have very atypical presentations of heart attack, which is usually the case scenario and which is usually the reason why it is missed when you are having a heart related symptoms. So so to speak, people would generally consider a chest pain as a major symptom of a heart attack. But however, there can be a myriad of symptoms which it can present with. Sometimes it can be just uneasiness, sometimes it can be just sweating, sometimes it can be just a headache, or just a giddiness which it can present with. So all these would have a lot more explanations which one would give themselves before they would consider heart attack as the reason. But I would say anything which is sudden onset and which is not resolving within a 15 minute to half an hour's time and which you never experienced before should generally be checked by a doctor.
I mean, that's a very interesting point that you brought up. Actually, I wanted to touch about this. Movies have a very dramatic way
Oh
of
yeah.
showing a heart attack, right? Like, it's like holding herself and like falling on the floor, and
Yes.
it's like, okay, unless I'm getting that kind of a symptom, nothing is wrong. But I've like I said, like a lot of people in family, I've seen these events happen with, and it's also personal for me because I also have a heart condition.
Okay.
So what I have come to realize after experiencing some of these things is that these symptoms are not exactly like how they show in movies, right? So for
You're
example,
absolutely right.
I
Yeah.
know of a person who was very very fit, right? And he just had a bout of vomiting, right? And then it was later on identified that, like, it was an heart attack, right? And then I know of people who had, like, in their sleep they have a difficult time breathing, only the wife could hear it, and it was a coughing which was very awkward, and then they later on realized that it is a heart condition that they're going through. So generally, in your experience, like, just to go a little deeper on these atypical symptoms, what kind of symptoms one should see and say that, okay, like, I really need to go and see a cardiologist, or I who should I go to? Like, I should go to a doctor immediately. Um,
So, thank you for that wonderful question. I think that is the most important thing. Even we struggle with in trying to tell people that what would be considered something abnormal. So, let's take this quote unquote term called gastritis. So, I've had patients come to my OPD and say, yesterday I had gastritis, doc. So I would just like to say it out loud there for the public here that when you have a burn in the chest, it could be a symptom of heart attack, period. So something which you have never experienced before, something which is not going away with all your so generally somebody who's not a diagnosed person who's having a gastric or a duodenal ulcer, even them, they would be able to quickly
Or your antacid is not
yes,
working.
antacid is not working. They'll be, that's exactly what I was coming to. So if you're, they'll be able to quickly be able to sort their symptoms out in a span of 10 to 15 minutes by taking any over the counter antacids. So when you know that you know you're having a kind of a chest burn which is slightly different and your antacids are not working, and I would say sometimes so-called gastritis symptom associated with sweating. So most of the time sweating is seldom a symptom of just pure gastritic pain. So in fact you would be more feeling more hot, but this body becoming cold and sweating is usually a cardiac symptom. And I would say instead of delving into it so much or giving it so much thought, anything which doesn't auto settle itself by something over the counter measures which you're taking in the next 10-15 minutes should be immediately brought to the attention of the local, I mean, or at least ECG needs to be done.
Mm.
So we've had a lot of times patients come and tell us that like he was fine, we've given him Pantop, now he's not waking up, or like in fact it was in my own family that this had happened. So that it was being self-treated till the point where ECG could have easily picked it up earlier than actually treating it just like it was a assumed gastritis. So steering clear of gastritis, the other thing which people are generally confused about is between a heart attack and angina.
Mm.
So angina, what you just described, like how it is dramatized in the movies, is a typical symptom, which is basically somebody holding down their chest. It's in fact the first time heart attack was diagnosed by one Mr. Levine was based on the fact that he was holding on the chest. And since then it has been like the only symptom which people watch out for. So the other things which can generally be there is, like I told you, can just be some giddiness and sweating, and
Mm.
also it can be something like they have been walking all along their life. They were able to walk a particular distance, and simply put, now for the past 2 days they're not able to do so.
Mm.
So any
Shortness of
change,
breath.
yes, any change in what is your otherwise normal should herald, and also should give you a slight hint that it could be something related to cardiac going on.
Yeah, it's so confusing, right? Because sometimes that shortness of breath thing. I mean, in my own case, right? I ignored it for the longest time, thinking that I am not exercising,
Correct.
right? And then I later on realized that the fact that I couldn't climb 2 stairs of flight while getting shortness of breath actually meant it wasn't that I wasn't,
Mhm.
it wasn't. It wasn't fitness. It was
Correct.
essentially the heart giving you a signal that
Correct.
you can't take it.
So one important symptom which you had mentioned earlier was somebody noticing, a wife noticing a husband who's coughing in his sleep. So what happens here is that all of us, in fact, all of us, when we sleep on the bed, there's an extra amount of fluid which comes from the legs, which is otherwise confined to the legs while we are standing and up and about, which comes into the heart. And generally, in all of us, that extra amount of fluid which comes into the heart from legs is accommodated well without causing any symptoms, unless you're already running a tight balance there. So, which is usually a symptom of heart disease. We call that in medical terms as paroxysmal nocturnal dyspnea, PND otherwise. So
Mm.
it essentially simply means that the heart is not able to accommodate any extra fluid. It's already running on a tight balance. So any amount of exertion where you increase the heart rate, or any amount of fluid which comes in extra into the heart, it's just not able to tolerate and gives you a symptom saying that I'm not able to take this anymore. So these kind of things should actually, and generally something related to heart is something which is reproducible.
Mm.
And like for example, if you feel that your something is abnormal, you pay close attention, walk the same distance, and see if it comes back again. Immediately see a cardiologist, I would say,
Mm.
because it's better that you do. So a lot of people do this, that when they when I ask them that you've been having this chest pain for 1 month, why have you come now? They say that that particular tree in the park, if I walk till there, I was having chest pain, so I used to walk short of that. So this is a coping
Correct.
mechanism.
Yeah.
Simply put, it's denial. So it's just not needed because we have gone leaps and bounds in technology now to be able to pick it up much before it can cause any harm to the body. And I would say people of this age should be more proactive into kind of picking it up before it can cause damage, because we are in that era where AI is like, trying to predict things before they can happen. So here we are, when a symptom has set in, rather than being in denial, should give a um, good fair chance of investigations, so that we have that lead time in like, taking care of it before it causes an issue.
So that, kind of gives me like a segue into why this happens. You're one
Sure.
time in your age you're doing well, and
Yes.
then suddenly like you have this condition to deal with. So, what are the usual contributing factors for a
For
cardiac arrest or for an heart attack?
Sure. So, I would say here, when I have to summarize all the patients whom we deal with on an OPD basis, it is two major entities, which is uh, heart attack, or basically blockages in the arteries of the heart, and it is heart failure, which is what we were slightly discussing earlier, saying the heart unable to take care of body's needs. Essentially, it is that. So, talking about heart attack or blocks in the arteries, it has its own blood supply in the form of two major arteries. Arteries are the pipes which essentially take food for the muscle or any organs, I think everybody knows. So, two major arteries are the ones which take blood to the heart. And generally, there are some areas in the body where, in these arteries itself, where cholesterol starts to accumulate.
Mm.
So a lot of people think that, like, a lot of attention on calcium also in the coronary arteries is being brought out these days. So it's not always that the cholesterol rises in the blood level, and then after a particular point it starts to accumulate. To be honest with you, we have not even scratched the surface of what really causes this cholesterol to go and settle down in the arteries. So I would be very um, I would be very correct, in fact, if I would say we know only 10% of the reasons why this happens, out of which a particular level, which is there on all our blood tests there on the right, saying this is the level to which it is to be optimal, or this is very high. So, yes, that is one of the reasons it can happen. That's not the only reason. Because other thing is risky behavior. So, you may have a normal cholesterol value in the blood, and if you are a person who smokes, who is having a high blood sugar, or if you simply sedentary couch potato whole day, how that kind of changes the whole dynamics of the body is that at particular given time, there's a lot of available cholesterol which is freely floating around for it to go and accumulate in the blood arteries. And not to mention, the most important non-modifiable risk factor as we speak is genetics. So
Mm.
a lot of it is genetically scripted. So if it were to be 1 plus 1 is to 2, we would be able to crack that equation very soon. So every time, in fact, every day, all of us see patients who are having a normal cholesterol but have already come with a heart attack. So which
Mm.
means that this has been accumulating for a year's time, and then it has already caused a block there, and it has basically come with the worst form
Sorry,
of
so
its.
there are cases with artery blockage even with normal cholesterol.
Yes, all the time. In fact, there is a lot of data, or also a lot of awareness about LDL being the bad cholesterol and
Mm.
HDL being the good cholesterol
That's
in the
the
public.
that's the conversation these days, right? Like
Yes,
this is
yes. So my blood,
triglycerides, HDL,
that's right.
LDL, very confusing ways to walk around.
Correct. So I would like to say this, that it's not one particular thing. It is basically a particular risk factor, and how the whole body, the host, plays around with it, and, like, then ends up having this disease. So in fact, it's a whole uh, segment of a biochemistry itself called as epigenetics,
Mm.
where you may be predisposed to something, but a lot of things, environmental factors, like you may have the gene responsible for it, a lot of environmental factors decide whether you'll be able to express that gene and have the disease thereof. This simple thing is called as epigenetics. And so which means to say that it's not that all the people who have had heart attacks in their family end up having heart attacks, but it's a myriad of things which come into play and cluster into forming a heart attack. So the general misconception which people harbor is that if heart attack is 100% cut off, as I mentioned earlier, so a person with a 10% or a 20% is not at a risk of heart attack.
Mm.
That's the usual misconception which I generally dispel in my OPD also, saying that, so when somebody has come to me saying that, doc, I've done my treadmill last month and it's normal, so am I not going to develop a heart attack? Or somebody who's already come in with a heart attack would tell me. In fact, it's happened even last week, and it keeps happening to every cardiologist, that I've had my annual checkup turned in last month and it all came okay, and the doc said that your treadmill was okay. So I just want to dispel a major notion here that treadmill or any stress test which we do, or on a daily basis walking ourselves and keeping ourselves fit, will rule out only one thing, that we don't have heart failure, which is basically heart's inability to be able to escalate its function as per body's needs. And the second thing is we don't have a tight blockage,
Hmm.
something to the tune of 70 or more in one of the major arteries in the heart, as I mentioned. So apart from this, it doesn't tell us anything. So you can have a 20% accumulation of lipid there, and you can have some same person go and do an unaccustomed exercise whereby he has shot his BP up, or like he has done a vigorous exercise or a vigorous stress he goes through. That 20% lipid which is accumulated in the arteries can rupture, and when it does so, it causes an arterial plug almost instantaneously, which causes a heart attack.
Oh.
So it's always a clot, a blood clot, which causes the heart attack. But the blockage prior to causing a heart attack doesn't need to be something which is to the tune of 70 or 80% or even 100%.
So before we come to the prevention, I just want to close the piece around cholesterol. So it cannot be taken as a free pass also, right? Like high cholesterol is a risk factor for
Yes,
sure.
it is
It
for
is,
sure.
right? Like people, I think, by confusing the conversation can go both ways. So, but now another set of conversations have started around statins, right? Are statins useful? You don't need to do statins. Like there's some people on online going on saying, cholesterol is natural part of your body. How can something natural damage you? You
Yes.
don't need statins. What is the latest thought medically on this?
So I think what has stood the test of time is that statins prevent heart attack. It's uh, it's irrefutable evidence that statins prevent a heart attack. So I've in fact had last week I've had somebody who said that I'm willing to take the chance. I want to go off statins,
Hmm.
and I am checking my LDL every day, and then yes, I am going to keep it under like below the bay. So this again brings us back to a discussion that lipids have to be beyond a certain point of time, point level for them to cause an issue. And the second thing which has been time and again proven with statins is their pleiotropic effects, which I mean to say is that it is not only by reducing the LDL that they work in preventing the heart attack. They have anti-inflammatory properties, and they also have a lot of other good effects which kind of trump over all the any existing side effects they have
Hmm.
when prescribed in a person, uh, like in the correct context of scenario.
So it's not only for cholesterol; it's actually for your heart
Yes.
health that is being given.
Yes. So I would say that, in fact, there are a lot of studies which have tried to see if statins prevent atrial fibrillation. So these are all large studies which have been done, which have not proven that statin is definitely only drug to be given for atrial fibrillation or any other factors, but it is based on the fact that statins have other benefits as well.
Hmm.
So why is, when you look at why are people going on a debate, it's again back to the same debate like how people had when COVID vaccine came in. So the pro-vaccine guys and anti-vaccine guys, but all of us are a testimony to hear say that, the vaccine has definitely helped curtail the disease so much that we are not bothered about the diagnosis anymore. So the same way, there have been a large randomized studies and large meta-analysis data which have irrefutably shown that in a person who's at a risk of or also in a person who has already developed a blockage for that not to progress, statins are the only thing which will help in preventing a heart attack. In fact, previously there used to be a trend of giving ecosprin for everybody who is beyond
Hmm.
40 years of age, and
That's
that
blood
is,
thinners,
yes,
right?
that's blood
Yeah.
thinners.
Hmm.
Ecosprin is an aspirin, which is a blood thinner. So that has kind of faded away now, to a tune that they've understood that most of the time these two were being given together, and whereas the actual hero was only statin. So, and you are unnecessarily taking blood thinner and risking yourself of a bleed with
Hmm.
very minimal benefit, which is why nowadays a lot of doctors are stopping blood thinner when it is there just like that, when they've not had a heart attack or any event, just as a preventive measure. If ecosprin is being given, a lot of doctors are actually steering clear of writing that.
So then, coming from treatment to prevention, right? I mean, people who are still young, people who have still not been diagnosed, right? what are the steps that they can take to prevent getting a heart attack? Like take good care of their heart.
Sure. So I would say I think one needs to all of us who are educated and beyond 20s, one needs to basically take a good look at how their family genetics have been mainly,
Hmm.
and rather than what is already obvious. Of course,
That point, I'll just say, like I've seen people match. It's kind of airy. I've seen people match the age of their parents or relatives' heart attack exactly to the T. Right? People who have, I know people whose mothers had heart condition in early 30s. They also got. I know a gentleman who's actually a fighter pilot. His father had in early 40s and dot on clock, even though super fit, early 40s. So it's
it's
amazing how it's literally time with genetics.
so like again reiterating the point that we know very little.
Yeah.
Despite all the years of research, it's only 10% that we have kind of, so suffice to say that we have just scratched the surface. So which is why uh, if I were to make a statement saying anybody above 40s needs a preventive health checkup, that wouldn't be appropriate for people who are having a heart attack which is running in their family, or a sudden cardiac arrest which is running in their families when they're in their 30s or even 20s or even late teens. So if anybody has had a heart issue at a young age running in the families, these are people who should right away, at whichever age they need to see a cardiologist. And when we talk about prevention, yes, there are a given things which everyone knows, that you need to keep, if you are a diabetic, you need to keep your sugar under control. And if you are having habits like smoking, you need to steer clear of. So smoking, vaping, smokeless tobacco, all are equal.
Vaping also.
Vaping is also bad. So
Okay.
vaping not just causes
Because they say
lung.
there is no tar in it and all that thing,
Yes.
right?
So,
So,
but then the point remains that the nicotine is the culprit here.
oh, okay.
It's whichever way it goes. Like if it goes without smoke, with smoke, doesn't really matter. So that's the reason why we see the same amount of. In fact, smoking tobacco leaves was not as common as actually chewing in North India, but we still have the same rates of heart attack. So smokeless tobacco
Okay.
is no tar at all. So, but the nicotine is what is causing the issue. And when it causes heart attack, it causes the same way as it does in anybody who's taking it in any which form.
So,
So
how about food? Like, what kind of food should we avoid? Like I've had so much conflicting input in saying, for example, eggs. People say, oh no, yellow part is the nutritious part. And if you say, oh no, yellow part is the cholesterol part, you will die eating it. Like, so
yeah.
what is, like, how do you think about food essentially?
So I think essentially one needs to understand that it's not more about what type of food, how much amount of food is
Hmm.
what matters. So someone can do a harm to themselves by eating just eggs every day also
Hmm.
as a substitute. So when I want to clarify the myths around food, I would like to say that like if you were to be a rice eater and you substitute rice with chapati, which is what most of the people do, you are substituting a carbohydrate with a carbohydrate again.
Hmm.
The body looks at it the same way. It's just that the amount of the calories for the amount of carbohydrate you eat may be slightly lesser in chapati, but a chapati or a roti or a maida is basically going to give you the same amount of glucose and the same form of carbohydrate. So I would say, even if you were to be a white rice eater, let's say you reduce the proportion of your rice and increase the protein and fat in the content. Like, let's say you are somebody who's
So
eating.
fat won't increase your cholesterol and all then?
So that is the usual myth which there is around. So if you were to be somebody who's having cheese with your food, let's say, and also ghee with your food, the point of that is to not make it more tasty and end up eating more.
Hmm.
So if you are somebody who's having a adequate amount of ghee and somebody who's eating a lot of sabzi in your food, you would yourself find full and eat less amount of rice. So ergo, for the lunch, let's say you've had good proportion, one third proportion of ghee and also fat and white rice, that would take so much longer for it to burn inside your body than it would if you were to just eat that in the form of a white rice.
Hmm.
So all of us have what is called as a basal metabolic rate, which keeps burning calories in our body. And at a time, if you are giving you food which is gonna release all the calories at once for the proportion which you are eating, that is when it becomes fats.
if I hear you right, what you're saying is it's the very high content of carbohydrates more than
Yes,
worrying about, okay, did I have one extra ghee,
yes,
or
yes.
like one extra egg
In
is.
fact, I'm sure you are aware about this, that previously there used to be a myth that saturated fats are
Hmm.
bad, and then it's again come back. It's gone a full circle and come back now. So, and the concept of wheat belly has started to come. And also, so this is a gentleman called Alan Keyes. So he was the one who was kind of, the way it was actually diagnosed, or like or the light was shown on, was that they just looked at countries which are rice eaters, and like which are looking at fat eaters, and concluded that fats are bad. But it's not the other way. It's not that way.
Hmm.
Even the fats which we take needs to be broken down into into triglycerides, which is the basic component of the fats and the fatty acids, and then it gets converted into whatever we are calling LDL or VLDL.
Hmm.
So if you have at any point taken a high glycemic index, which is a high calorific value food, like then it is likely to convert into fats, because body doesn't know what to do with the extra calories which are there, and just converts it into fat. That is why somebody who's trying to lose weight, they ask them to steer clear of any aerated drinks, because they are empty calories. So they go and burst into calories. So that's the problem.
So the rule is like eat in moderation.
Eat in moderation, but have equal amount of carbohydrates, proteins, and fats in the food. And whichever, it doesn't matter if you're a vegetarian, non-vegetarian. There are enough ways now to kind of like I have encouraged my patients to even eat tofu instead of, because it's a very good source, vegetarian patients, because it's a very good source of protein, paneer. So they not only provide the food and calories which are needed, they suppress your appetite so that you don't eat too many carbs.
Hmm. So just to touch on that point of the saturated fats and unsaturated fats, right? There is a lot of conversation around cooking oils, right?
Correct.
And there is discussion on ghee is okay, sunflower oil is okay. People say if you have high cholesterol, you should have olive oil. So there is now a whole economy around the kind of oils you can buy. So how do we think about that?
So again, basically, generally speaking, we all need fat in a food, and more than the type of oil, again, it's the amount. I come back to the same point. So
Okay.
when I've had someone ask me whether I could eat fish, I'll just give you an example. So then I said fish is good. So then they've basically been consuming a fish fry every day. So it kind of negates the point why fish is good, because you are eating the fish for its protein and also the omega 3 fatty acids which are there in its skin. When you're frying it in our own refined oil, it doesn't matter if it's the safflower, sunflower, or any other kind
Or
of an
even
oil.
olive oil.
Yes, even olive oil.
I don't know if you can fry in it, but yeah.
Yeah, you can saute in it, but the point is this, that when you're eating it in such an unhealthy form on a regular basis, then it kind of negates the point of even a good food. So what I'm trying to reiterate here is that if there's a way of consuming it without deep fries, where you're kind of, the amount of oil which is going in and the form of oil which is going into your body is like very unhealthy, so it doesn't really uh, negate it by using a different kind of an oil.
Hmm.
So it was thought that extra virgin olive oil and safflower oil were better for heart, and there are some data to support that, but there is no data to make a statement that this will, taking this will prevent a heart attack. There is no
Okay.
enough evidence that.
So since eating in moderation is a very fair, easy advice. I don't know how easy it is to follow, but it's easy to remember for sure. But having said that, right? Then, and you said, like, for example, you said that okay, your genetics can also catch up with you. You can maintain your cholesterol, still you can get a heart attack, right? Even 20% arterial blockage can be leading to heart attack. So then it's kind of like little worrying, right? Like, so how do you? What kind of screenings can I do
Sure.
regularly, right, to just be little self assured that my heart is okay? Every one of us do like maybe annual health checkups and all, but like what kind of tests or what kind of screening should I be thinking about to check for my heart health?
Sure. So so when I hear most of the techies and also like everyone who's working out there do their annual checkups, it has a bunch of tests which are mostly starting for people who are 40 and above. Nowadays, people have even dropped it to 35, where you check your routine blood group and also your hemoglobin and everything. And along with that, you need to, of course, check your lipid profile and see whether you belong to the group who is having this high lipid profile without your knowledge. That's the step number one in trying to have a um, risk of heart attack reduced, to see whether you have unknowingly harbored a very high cholesterol in your blood, which is because it simply is asymptomatic. And also nowadays, there are no major symptoms one develops for diabetes, at least in the initial phases. Like, previously when it used to be thought that people lose weight, they have a lot of lot of thirst, lot of urination. So it can simply silently be there, because especially the borderline diabetics who are slightly on the obese side will just have insulin resistance and have sugars which are just north of 200 and be undetected. So sugars have to be definitely checked once in 6 months, and if not, at least a year, once a year. When it comes to pertaining heart investigations which have to be done, so when I give this analogy to all my patients who walk to my room, so when we look at heart, we look at it like, if I were to ask you to come to this room and give me a report of this room, what would you do? So you would look at the structural integrity of the walls, you would look at the electrical wiring, and if the electricity in the wall is okay, and if there were to be a faucet here or a tap, you would check if the plumbing is okay. So those are the three things exactly we look at when. So I get asked this question. The reason I say this on record is that I keep getting asking this question, like, is ECG necessary or echo necessary? Which is better? Is echo better or TMT better?
I will actually go one step further. There are a lot of people who doing CT also for
Yes. So I'll come
calcification,
to
right?
that. Yes. So uh, the point is this, that it's not one is better over the other. All of them in unison give us the information which we need to be able to make a decision. So if I were to ask you a complete report of the room, you would say that all three would be necessary. Coming and having a look at, you need to switch on the switch to know whether the bulb is working. So otherwise, looking at it wouldn't help you. So to reiterate the same example analogy, we look at the electrical wiring of the heart by doing an ECG, and we look at the structural integrity of the heart to know whether silently you have had a heart attack, or if you have a genetic condition which harbors you to have a cardiomyopathy. We would not know by just looking at the electrical signature of the heart in an ECG. So echo becomes mandatory then.
So
Or
echo just for all the audience is done through an ultrasound.
yes,
Yeah.
echocardiogram is basically where we apply a gel and look at the heart, how it works.
Mm.
So echo is otherwise an ultrasound of the heart.
Yeah.
That's about it.
Mm.
And treadmill or stress test, as we all know, treadmill is basically where they hook you up to ECG leads and make you run, and to see what happens to the, that indirectly tells us how the blood flow to the heart is.
Mm.
So all three will be, so when you have all of them coming out as normal, that is when the action confusion starts. So
Mm.
then somebody assumes that, okay, I'm good to go, and I should not have any heart disease, at least till my next checkup tells me what is going to happen. So that is
So
usually a
how frequently
misconception.
these three should be done?
So I
Like,
would say, in somebody whom it has
so
come back as
ECG,
normal.
echo, and TMT.
Yeah.
Right.
So ECG, echo, TMT, at least once it has to be done for somebody who is above 40, and maybe till they are 50 it can be repeated once in 2 to 3 years.
Hmm.
So when you are
30 is
talking
not
about,
required.
yeah, so 30, like I said, basically if you are at a high risk of developing a heart attack because of other reasons, the same thing would shift one decade
That
earlier.
is basically your blood reports on lipid,
Yes.
or if your sugar is high,
Or if
or
you
if
have
you have
had
a
a family,
history.
yes, if you have had a family history, there's nothing like being careful about it, and also not ignoring a symptom just because you're in your 30s.
Hmm.
We've been seeing a lot of young heart attacks as we speak. So since you brought up about CT, so what is going to be additionally told by CT is that, first thing I want to tell it out on record is that CT scan has been validated in people all around the globe only above 40 years. So a lot of youngsters, when I say that, it is only CT calcium which I'm saying about
Hmm.
that, not the CT coronary angiogram. There are two different, where we spoke about lipid going and silently sitting there to the tune of 10 to 20% in the arteries of the heart. So people have looked at it, and when it stays there for long enough, it becomes calcium. So slightly picking up the calcium instead of giving the contrast. So initially, if you were to pick up the cholesterol which is accumulated in the wall of the arteries, you have to give contrast. So instead of going around giving contrast to everyone, for such a I mean, it would be a laborious process. So people have come up with a better screening tool, which is to look at the indirect evidence of cholesterol, which is the calcium in the arteries of the heart. Unfortunately, this is being applied for even a young people who are being risk stratified,
Hmm.
for the sake of, like, looking at whether they can or not develop heart attack, which would not be very appropriate, because when you are looking at The next thing when you look at if you have a calcium spec is that how bad is this, and they Google it saying what is the meaning of my score which I have got.
Yes.
So I would say that it is a good tool. It has its own role in people who are above 40. And if you are above 40 and if you are thinking that your all tests have come normal, at least once in 5 years, you can get your calcium CT score done to be able to understand whether or not you require statins. It essentially answers only that question.
But let the interpretation be with the doctor, I
Yes,
think.
let the interpretation be with the doctor. Yes. So if you are
Instead
already
of
on
Google.
statins, I would tell you that this would be a kind of redundant test. If you, let's say your doctor has already put you on statins and like you are taking the statin, then you are only the blood report will tell you how much of a dose of statin you need to take.
Mm.
So
So, given that these things are happening, there are like now very, very young people who are even I think in 40s now, like fitness is catching up, and fitness devices are catching up, right? So there is this new trend of having devices which can track your ECG directly on your watch or some other device that you're wearing. How effective are those devices in checking your ECG? Are they reliable in terms of diagnosing yourself or monitoring your health?
yeah. So I mean, yes, it's both boon and a bane now having these wearable devices. Thanks that you've asked that. So I want to tell you that Apple generally doesn't have too many disclaimers, and Apple Watch, when we are talking about, there are a lot of other smartwatches there, but let's say take Apple Watch example. It itself comes with a disclaimer saying this watch, this ECG which we have recorded doesn't look for heart attacks.
Hmm.
So it is simply put. Uh, More accurate for us to be able to look at what our heart rate is. If there is any condition like in atrial fibrillation, we just spoke about atrial fibrillation. So atrial fibrillation is a condition where heart chaotically goes fast to a tune of 100 and 150. So those kind of things it can easily pick up. So I don't mean to say that wearable watches are not good and they should be not used. One needs to understand what you're using that for. So if you are having a chest pain and you're sitting wasting time on taking an ECG on the watch, I would say that that's a moot point there, because the watch itself tells you that it's not good enough to pick up a heart attack. And I want to say that the ECG, even though it comes out on a paper like how we take it otherwise in the hospitals, this is a single lead ECG.
Hmm.
So you're looking at only one aspect of the heart. So you'll be doing yourself a lot of harm by missing out on important information when you're going through a symptom by trying to diagnose this on your own. So I've had a lot of people who have had chest pain send me their Apple Watch ECG. So I would tell them with all due respect, please go to a local nursing home and please get an ECG,
A full 12
a
lead
full
is.
12 lead ECG.
Yeah.
Yes, because when we look at ECG, it's like cameras around your heart. So
Hmm.
each one looks at it from one aspect, and you look at it all 360 degrees so that you don't miss any part of the heart having a heart attack.
Fair. So, a lot of the technology and pharmaceuticals, everything, the original research and science has been done in Western countries.
Yes.
And I think we started this conversation with, the race differences
Yes.
also there.
Yes.
So how much of these scientific findings and all of these are primarily designed for Caucasian Western population, and are they fully applicable to us, or is there a variation? And like if there is a difference, how are we proceeding about it, like here in this part of the world?
So that's a very scientific question. So I would like to basically tell you the good news that a lot of newer drugs which are coming out, and also a lot of so there are non-statin therapies for cholesterol also. In that, we are proud to say that India has been at least 10 to 12% of a representative population. So a lot of centers around the world have basically opened up to the fact that we are doing good quality research here, and also we are in the world's limelight right now. So we are safe to say that even though there is no existing guideline based on the existing Indian population, but we are getting there where we would soon have in the coming decade our own data as to how things are working out for us. And meanwhile, uh, safe to say that we we have a lot of population here, and we have a lot of doctors who are following in implementing. We have not found too much of a discrepancy in what is being professed and what we are finding in our this thing. When you talk about, let's say, the efficacy of the drugs, but there are some data when we are talking about statins. There is some data which is told that the doses to which Caucasians tolerate, Indians don't tolerate, and safe to say that we have starting only at half doses of what is recommended, and we are finding good results with even the half dose. So that's just with statins per se, I'm saying. So we are making some tailor-made changes like that when we are treating our population,
Through
but
practice.
yes, through practice,
Mm.
yeah. But we would soon have our own data and guidelines to kind of go about this.
Phenomenal. And thank you so much. This has been very, very insightful for me personally, and I'm sure for our audience also. Uh,
Thank you for having me here. And this was a very important information to kind of like let the public know about various heart ailments that there are. And I would earnestly request people to not lose faith in the doctors who are around them, and please seek out help, professional help, when you feel something is off with respect to any symptom what you're facing.
yeah, especially, I mean, in case of heart conditions, right? It
Yes.
can just catch up on you.
Yes, because sometimes I mean, there's a saying where they say stitch in time saves nine, right?
Yeah,
Here it can even save a life.
phenomenal. Thank you so much, Dr. Edwin, for taking the time.
Thank you.
Really appreciate you coming over here.
Thank you. Thank you.
Thanks. If you like the podcast, please hit the subscribe button or share it with someone whom you think will need it.